In a second, I'm going to introduce you to our speakers, and we're delighted to have such a great panel of people for you to hear from today. But before I do that, I'd just like to welcome you from the spaces that you've come from into the space that you're in now, and invite you to join me as I acknowledge the ongoing and traditional custodians of the land that we are meeting, and the space that we are meeting in today. Where I put my feet on the ground, that's the Whadjuk people of the Noongar Nation. And I'd like to pay my respects to elders past, present and emerging. And say a real word of gratitude. I'm obviously not from Western Australia, perhaps you might be able to tell from the accent, but it's been a real privilege to me to be able to learn more about a culture that has such a strong and enduring connection to land. And so I will now move on to introducing our speakers. So today's format, you're going to be hearing from 4 speakers, and we know that this is a topic that is of great interest to many people in the community. At Health Consumers Council, we have been collating information about COVID and COVID resources from all of the various formal websites, and we've tried to pull them all into one place, and we'll be sending you lots of links after the event. But I'm going to be, and again, Anna, I might ask if you put up the slide that has the speakers on it. Thank you, Anna. And so I'm delighted to say that today we have a very illustrious panel of people who are going to be talking to us. In a moment, I'll hand over to Professor Chris Blythe, who is an infectious diseases physician at Perth Children's Hospital, so PCH, and is the former co-chair of the Australian Technical Advisory Group on Immunisation that you might have seen mentioned in the media, known as ATAGI. We're also welcoming Dr. Michael Baker, who is the co-head of the emergency department at Perth Children's Hospital, Dr. Andrew Martin, who is the head of Department of General Paediatrics, and thank you for making yourself known there, and Professor Nick Gottardo, who is the head of Oncology and Haematology at Perth Children's Hospital. So like I say, please do keep an eye on the chat, put some questions in there if you want. We may not have time to get more questions answered today, but if we have a lot of outstanding questions, then we'll see what we can do to be organising either another session or get some answers through another format. So without any more hesitation, Chris, I will hand over to you and invite you to get us started.
Thanks very much, Claire, and thank you for the kind introduction. It's great to talk to this group and at this forum again. So I'm just going to really cover a little bit of what we're seeing at a state level, and also then very happy to answer any of the immunisation questions or more broad questions in this space as well. If you could go to the next slide, Anna. So, you know, what we're experiencing at the moment in Western Australia is quite different than what is being experienced around the world. You know, we are now basically in the middle of a Omicron outbreak, and there's a couple of important points there. So we do know that previous variants were less infectious in children compared to adults, but also the health impacts were more severely felt by adults than children. Now, what's different about Omicron? We do know that Omicron is more transmissible, so in other words, more likely to spread from person to person, and including through paediatric populations. But we also know that the health impacts of Omicrons are milder than those previous variants. Now, I think it's really important to stress that's not to say that this is to be ignored, and many of the interventions that are occurring at the moment are unnecessary. It still has the potential to have a significant impact on health in our community, so they are necessary. But importantly, we're seeing things differently because we've got a different variant spreading in Western Australia at the moment compared to 2020 and 2021. If I could go to the next slide, please. So this is what's happening in Western Australia at the moment. And the reason I put up this slide is, you know, we have more than 200,000 confirmed cases of COVID in Western Australia at the moment, which is about 7.5% of the population.
Wonderful.
And I
Thanks,
put
Dale.
that there to really highlight that although Maybe if we could ask people to go on mute if they could, to highlight that actually we still have a long way to travel with our experience with COVID. And the other important thing to highlight is actually about 30% of cases occurring in children and teenagers at the moment. So there is plenty of infections occurring in the community at the moment. We're getting between about 6,000 and 8,000 cases per day of newly diagnosed infection. Now, previous data suggests from an impact on children, hospitalisation rates were about 1 to 2%, and most children were needing to stay in hospital for about 2 days. But actually, our data suggests that actually the numbers in Western Australia are slightly lower than that, which is good news. If I could go to the next slide. So how are we tracking? So these are data that have been generated by WA Health, really tracking the modelled epidemic over time. And the number of cases are actually pretty bang on to what we expect. This is the number of expected cases and the number of fake cases that we're seeing in the black line there. But the other really reassuring thing, if I could go to the next slide, is our hospitalisations. The impacts on ward admissions is lower than expected in all age groups, including in children and including in adults. So really quite reassuring about impacts on our health system. That's not to say our health system is not having to flex at the moment to combat against COVID, but importantly, not as much as we predicted. If we could go to the next slide. And this is ICU admission. So thankfully, our most acute areas in the hospital at the moment are coping very well with our Omicron wave as infections continue to climb. Now, I don't know when our Omicron wave will peak. I know there's an expectation that it'll peak in the next week or two. I think there are lots of factors at play at this stage, and I think we have to continue to be COVID aware and be thinking about COVID for some time yet with community restrictions in place. Could I go to my next slide? I actually think that West Australian children and adolescents appear to be tolerating the current COVID way really well. And I think this is important because, one, we are seeing this is a population that is at lower risk of severe outcomes compared to older Australians. We are seeing the impact of less severe variants, but also really highlighting that actually we have high vaccination coverage in our 12 to 15-year-olds. Really, more than 19 out of 20 have received their first dose, and second dose protection is nearly 9 out of 10 individuals. And starting vaccinating children in January this year, nearly 2/3 have received a first dose, and actually our second doses are now starting to climb because many of those children have been eligible for their second doses from March, and that's the recommended 8-week gap. Lastly, there is not a vaccine for the 0 to 4 years. I do expect it will be some time before we have a vaccine. They are in clinical trials at the moment, but some of the outputs from those clinical trials suggest to me that actually we've still got some way to go. But I think the other important thing is actually we've had 2 years to hear about COVID, to understand about COVID, to make ourselves as a community and as a health system familiar and aware. And I think that's actually helping communities. And I'm really interested to hear this group's thoughts on that as well. And with that, I think I'm handing back to Michael for the next section.
Thank you very much, Chris, and thanks a lot for the opportunity to speak today as well. Just the next slide, please. As Chris alluded to, we had the real benefit of learning from the Eastern States experience and seeing how the COVID situation has played out over the last 9 months. And as part of that, we have followed the WA state guidelines on how to run an emergency department during times of high community transmission of COVID. And so what we have done is split the emergency department into 3 physical streams with physical separation between the streams, depending on why patients are presenting to the emergency department and their COVID risk factors. So we have a green stream, and that stream is for patients with no COVID risk factors, no symptoms of COVID, and that the accompanying caregiver also doesn't have any COVID risk factors. We have a separate triage area for that and separate waiting rooms, and they go into separate areas for their ongoing management. Next, we have an amber stream, and that's for the possible COVID. So that's for patients or caregivers coming with the patient who have either some symptoms of COVID that could be consistent with COVID, or patients who have some risk factors for COVID, some potential exposures. Once again, they have a separate waiting room, and we have numerous isolation cubicles so that we can safely manage those patients in isolation. Finally, we have a red stream, and that is for COVID positive patients. All patients who it's highly likely they have COVID or the caregiver that has COVID. Once again, that is a separate unit. And one of the real benefits of having a long lead into the planning phase and a long planning phase for this has been to really set up our airflows and reduce the chance of transmission of COVID from one person to another. So our airflows are really maximised, and so that as well within the department. So really this makes sure that we can safely manage our normal ED presentations while accounting for COVID. Can we go to the next slide, please? So what's our activity been like? Activity, we've seen about in total 50% of our patients are going through the amber stream or the red stream. So currently we are seeing 1,245 patients in a week. So that's about 180 patients per day. That's in total. We're seeing about half through our green stream and the other half through our amber and red stream. This means that in total, we're seeing about 15% of our patients have COVID or very likely to have COVID. Thankfully, though, the actual number, as Chris alluded to, the actual number of patients who are requiring admission is very low. So currently, about 1 in 10, 1 in 20 patients actually need admission, and 8 or 9 out of 10 patients are well enough to go home. Next slide, please. So what are we seeing with kids with COVID? Well, in general, it's presenting with a mild illness, which is fantastic. And I think that's the combination of the fact that we're seeing Omicron and the high vaccination rates in the age group we're seeing. So in a large amount, it's actually presenting like a cough or cold illness, like any other cough and cold illness. And clinically is not really distinguishable from any other virus. So we're seeing fevers, we're seeing quite a bit of body aches, and also chills. So, that feeling that you can't get warm. Often that only lasts for a day or two. Patients may come in lethargic, so a bit more sleepy than usual. But once again, this is usually only lasting for a day or two and gets better quite quickly. We are seeing a bit of cough, but sometimes cough is not present. Congested nose, not much sneezing. But one of the main features has been a sore throat. And what we're finding compared to Delta, which was largely a disease that affected the lower respiratory tract or lungs, Omicron is affecting the upper respiratory tract. So patients are frequently coming in with a sore throat. The other feature we are seeing is a croup-like illness. So croup is the effect of a virus, and which leads to a little bit of swelling in the breathing tube. And patients often have a hoarse voice, may have a hoarse cry if they're a baby, and may get into some breathing difficulties and some noisy breathing. And we are certainly seeing that in the patients presenting to the emergency department. The other feature of Omicron is GI upset, so gastrointestinal upset, and we are seeing patients with some diarrhea, some vomiting, and also a sore tummy, which kind of comes and goes, is not really specific, not in really one position or another. Often this is towards the milder end though. We are seeing patients with headaches, and one real characteristic is younger babies with poor feeding, I think because they're feeling just generally unwell and congested nose. What we're not seeing, which is more the feature of that Delta and previous variants, is severe difficulty breathing and low oxygen levels, which is fantastic. Next slide, please. So when to get help is always a question. What do I do if my child's got COVID, and when should I come into a hospital is one of the key questions. And we've created a traffic light system to help guide parents to decide how to get help and who's the appropriate person to go to first. Next slide, please. So as I alluded to, most children with Omicron actually have a mild illness, a mild cough and cold illness, and actually can be treated at home and rest at home and recover, keeping the fluids up and Panadol or Nurofen if they've got aches and pains and they're uncomfortable. So then there's the amber set of symptoms, and what I'll say about this is number one is trust your gut feeling. You know your child best. And if you think, you know what, this is abnormal, this is more than a normal cough and cold, then that's your prompt to seek help. If they are having difficulty breathing, or they might be a bit more sleepy than usual, if they have pain that's not going away with Panadol or paracetamol or Nurofen, we are seeing aches and pains, sore legs, sore tummies. Sometimes they get some mild discomfort in their chest, arms and legs. But if that's not going away with Panadol or Nurofen, then contact your GP. Mild dehydration, so when they're drinking less or vomiting, diarrhea. If they're feeling a bit lightheaded, a bit dizzy, it's coming and going, otherwise they're fine, then see your GP. Pain or swelling in legs, this is uncommon actually. Usually it comes on and it goes away quite quickly, but if they've got persistent pain in their legs, that can be a sign that they need to be reviewed. A fever lasting more than 5 days is in there because at times people can start with COVID, but then they can get an infection on top of it, such as a pneumonia or an ear infection. And it's worth checking in with the GP if they have fever for more than 5 days to ensure that there's nothing else that has occurred in the meantime. And similarly, a fever in a baby less than 3 months old needs to be checked in with the GP so they can review. We understand that access to GPs at times can be difficult, but almost all GP practices are offering telehealth service where they can phone or video call into the home and review your child. There are also specific COVID respiratory clinics around Perth and country areas where you can get face-to-face assessments by a GP. Next slide, please. And finally, the red symptoms. And this is that really, that feeling, I know something's wrong with my child, I need to get help. And these are all reasons to come to an emergency department immediately. And if you're really concerned, you call 000. So that will be severe difficulty breathing. Thankfully, we haven't seen a lot of that. But it is, if your child has severe difficulty, you come in. The other is if they're confused. So not just a bit tired, not a little lethargic, but they're actually not making sense. Or they can't keep their eyes open. A severe headache, chest or abdominal pain. If they are actually fainting, or they actually often feel like fainting, if there's skin changes, so this is a sign that their body is really trying hard to fight that infection, or that there's a more severe infection overlying it. So if their skin is cold, or if they feel sweaty and clammy, they're pale, or they're spotted or patchy blotches to their skin, of course you come straight in. The other is if they're just extremely weak and floppy, particularly with the babies, then that's another sign. And of course, lips or face turning blue, that can be a sign of low oxygen levels. So thankfully, we haven't seen much of that, but any of those signs or symptoms should come straight in. Next slide, please. So, you know, I always say to parents as well is that you trust your gut. So if you are worried and you can't see a GP, you come into an emergency department, we are always there for you. We're here 24 hours a day. Thank you.
Great, thank you. Thank you, Claire, for the opportunity to talk today. Next slide, please. So I think Chris and Michael have already covered much of this, but really some of our experience on the inpatient wards is that the vast majority of children who test positive to COVID manage very well. So they have mild flu-like symptoms. As Michael said, it's often a low-grade fever, a runny nose, sore throat, less often a cough, and often some gastro symptoms of vomiting and diarrhea. But it's really no different to the symptoms that children get, particularly in winter, when we see a surge in viruses every year, and COVID is really behaving like another virus, which is giving children those symptoms. Next slide, please. So if your child tests positive to COVID, very clearly you need to isolate at home. I think some of the questions in the chat have been around how do you balance that as a parent if one child's positive and another child isn't, or one parent is, and that's I think there's no simple answer to that. It is difficult. It often will obviously be different depending on the ages of your children. If you've got teenagers, it's a little bit easier for them to isolate and keep their masks on and come down and eat at other times. If you've got little babies, it's hard. So you've got to be sensible and pragmatic about it and manage it as best you can. Monitoring your child's symptoms, and as Michael said, you know your child best. Those symptoms, when you look at them at one point in time, it's often, it looks fairly sort of clear cut, that child should need to come to hospital. What's really important is the monitoring over time. So if a child's got, difficulty breathing, but the next day they're a little bit better and they're moving in the right direction, that's much more reassuring than a child who's early on in their illness and is developing worsening symptoms. So the sort of sequential monitoring of symptoms, and you as a parent will be able to do that better than anyone. For children who've got underlying medical conditions, and we'll talk about this a little bit more in the next couple of slides, it's really sensible if you have a normal treating doctor. That might be a GP who you know really well, who knows you and your child, a paediatrician or a subspecialist here at PCH. If your child tests positive to COVID, get in touch with them and let them know. So that's important to do. And then as far as the treatment and care, it's really so it's managing your child like you would normally manage them with a winter viral infection. So if they're not drinking as much, trying to keep up with their fluids, small amounts more regularly, particularly if they've got a fever or they have any vomiting and diarrhea. If they've got a fever, we wouldn't normally give paracetamol or ibuprofen, but if they're uncomfortable or irritable or in pain, then absolutely appropriate to give that to make them more comfortable. Next slide, please, Anna. So as far as what we've been seeing here at PCH, I think it's really important to stress that children who are testing positive to COVID are being admitted to all hospitals around Western Australia. So it's not something that needs PCH tertiary care. It's only in a tiny number of cases. So most children can be very safely and very well managed in their local metropolitan hospital or in any of the regional centres. Here at PCH, we're seeing on average 3 or 4 COVID positive children being admitted to our hospital. So it's, as Chris mentioned at the beginning, it's smaller numbers than we were sort of anticipating. I guess it might be worth putting that into context as well. If you think we're having around 1,500 to 2,000 children at the peak testing positive to COVID each day. Of those, we're getting about 30 or so coming through to our PCHED, and then about 3 or 4 of them getting admitted. So the vast majority of those children at 1,500 to 2,000 who are testing positive across our state each day are being well and safely managed at home. The reasons why children who are testing positive to COVID are being admitted to hospital, there are, I guess, 3 things, 3 main sort of categories. The first is the COVID, again, as another virus. So, every year we get children with RSV infections, with children with influenza and other viral infections coming into hospital with symptoms, and COVID's causing the same sorts of symptoms and illnesses. So babies who may have a snotty nose and generally breathe through their noses may have slightly more problems feeding and get dehydrated. Michael's already mentioned croup as an issue, which seems to be particular to Omicron. Again, in the chat, there were some questions about asthma specifically, and asthma's, it's been very reassuring that certainly with the Omicron variant, it has not been an issue. So we haven't seen children that have got asthma, and even some of those with more severe asthma running into problems with their asthma when they get COVID as a viral infection. The other groups of children we're getting is the children who have got other illnesses. So children will still get acute appendicitis, children will still get urine infections, and children will still fall off the monkey bars and break their arm. And because there's so much COVID in the community, they're COVID positive at the same time. So that's another group who are coming into hospital. They need care and they're COVID positive, but it's one of the normal sort of standard illnesses or injuries that's bringing them into hospital. And then a really small group, those children who've got a significant underlying condition. I'll talk about this in the next slide. And we may have a slightly lower threshold for some of those children to bring them into hospital for observation in consultation with the parents and other people in deciding whether it's a period of time in hospital might be helpful. Next slide, please, Anna. So as far as management, the management of COVID positive children in hospital is really treating the symptoms. We're not treating the underlying COVID infection. So if a child presents with croup, then we manage the croup. If they present with predominantly gastro symptoms and vomiting and diarrhea, then we rehydrate them and manage those symptoms. Obviously, when children are in hospital, we're observing them closely, and nursing staff are doing regular observations, and we will respond to changes over time. But the vast majority of children who are coming into hospital have it's already been mentioned that a relatively short length of stay, 1 to 2 days, which is about our average length of stay for most children with other viral infections, which isn't COVID. So it really is behaving like another viral infection, but it's the one that's in our community at the moment. Next slide, please. All right, so this is slightly different now, just talking about the COVID Care at Home program and SPARK, which is our statewide pediatric and adolescent remote care service. So I hope that people will be aware of this. So this is really trying to provide some support and care for children and adults, so for all of the population who test positive to COVID, and to do that safely in their home. We're really trying to pick out those individuals, children and adults, who might be at higher risk of developing complications when they test positive to COVID. So the COVID Care at Home program is a collaboration between the Department of Health, so WA Health, and Calvary Medibank. And they set up very similar programs in every state across Australia to allow individuals who have got underlying medical or psychosocial issues to be safely managed at home. So COVID Care at Home, I encourage everyone, if your child does test positive, to sign up for that. When you get sent a text from the Department of Health saying that you've tested positive, that's done by a PCR, then there is an invitation to join or to register for COVID care at home. Equally, if it's done by a RAC test, you upload it, then you will follow a link, and it's what essentially happens then, you have about 5 very simple screening questions. And what they're trying to do is trying to screen out whether you've got any, or you or your child has any high risk factors, which would mean that they would be a part of COVID care at home, or if there are no risk factors, they can be sort of low risk, and you can be safely managed at home. You'll be sent a lot of resources and information on how to care for yourself or your child, and how to call for help or escalate care if you're concerned if things change over time. So COVID care at home, you can think of as the overarching, it's a statewide program from children and adults, and provides that support. It's with telephone support. Spark is what we've set up here at PCH. Again, it's not a PCH centric, it's a statewide service for children under 16 years of age, although we will, if there are children up to the age of 18 who are still being cared for by subspecialists here, we will also care for them. And it's for children who have got really the pointy end, the very significant underlying medical risk factors. Nick will talk a moment about children with cancer, and that's one group who we would be wanting to monitor and provide support at home, because they don't all need to come into hospital, but we want to be able to provide that support at home. So it's children who are under dialysis, children with significant underlying cardiac problems, so possibly children with congenital heart disease or respiratory problems like cystic fibrosis. The service is managed centrally here at PCH, and children who are on Spark will be reviewed by telephone or video call as required, but most of them sort of daily. And importantly, what we do is we link up with the child's usual treating teams. So it's very much a collaborative effort. For children to be eligible for Spark, they need to have those underlying conditions. So they can either be referred directly from COVID care at home, and that is a sort of fairly seamless process, or even sort of quicker if your child does have a significant underlying medical risk factor and you've let your usual treating team know, if you've given the clinical nurse who you have contact details for, or even one of the medical teams, if you let them know, they can let us know, and we can then pick things up. We've been running that since the end of January, and we've had over 100 children now managed through Spark. I think our experience is that even those children with very significant underlying medical risk factors, even that group, the vast majority are safely cared for at home, and we monitor them for between 7 and 10 days, depending on their underlying risk factors, and the vast majority of those children are safely cared for at home. Occasionally, we will ask a parent to bring a child into hospital if we would need to have some bloods checked or be reviewed by one of their subspecialists, but even in that group, the vast majority of them are being safely managed at home. I think that's it for me. Next slide.
Okay, it's my Nick Gattado here. It's a real pleasure to be here, and thanks also for the invite to share some of our insights on children with cancer and some of the blood disorders that we treat in our unit. If I could have the next slide, please. I've split the data into 3 segments. A bit like Michael spoke earlier, we have been very fortunate in WA to have been protected by the shutdowns, etc., which have really allowed us to learn a lot from our international and also more recently our national colleagues. It kind of has given us a heads up, and of course our population of patients, we were incredibly worried at the beginning of this outbreak that because children with cancer receive very intensive chemotherapy and radiation treatment, our concern was that they would potentially be more vulnerable and picked off by this virus, which is often the case with very immune compromised patients and particularly children. And that really didn't seem to be occurring with the first wave that was happening internationally. There was a hospital in the United States known as St. Jude's Children's Research Hospital, which happens to be where I did some of my training. And they collected data from all over the world. And with the first wave that occurred, there definitely was a concern that children with cancer were being affected more than children without cancer who were not on anti-cancer treatment. But this data was all countries from all over the world, including developed and developing nations, where levels of care were not as good as in developed nations. And so we did see that children with cancer had about a 3 times higher rate of having more severe disease than children without cancer. But it does come with those caveats. So one of the things that we did as a national group is advocate very early on for our children to have the only thing that could protect them, and that was vaccination. And we worked very closely with ANZCHU and on all the different cancer centres around Australia and New Zealand. And Chris joined many of those calls, Professor Chris Blythe, who talked earlier, in coming up with recommendations. And that was really our first port of call, was to protect our children. And also we call it like a wall of defense, and also recommend that families looking after the children were also all immunized, so that there was this sort of natural wall of protection around them. Next slide, thank you. And this is a website that I recommend that you guys go to. It's our national group for cancer and blood disorders. It's known as ANZCHU, which stands for Australian New Zealand's Children's Haematology Oncology Group. And there's lots of advice on there with regards to vaccination recommendation guidelines, and a lovely section on frequently asked questions, which we try and update, because the data around vaccination guidelines is constantly being updated as the vaccine becomes more readily available for younger age groups and the booster doses, etc. And so that gives you general advice. And also I recommend obviously speak with our team and your oncologist and our nursing team around the specifics around your child, because obviously every child is different. Next slide, thank you. So our national data really pleasingly is consistent with what both Michael and Andrew have shared with you, is that and this is as of March 21st, I've got more up-to-date data for our own unit. So whilst we in WA are going through our first wave, and our New Zealand colleagues are in a similar position because they had also very good sort of isolation from the rest of the world, the eastern states are a little bit ahead of us and are actually in their second wave, having had much greater numbers. And what the data shows really that there hasn't been an enormous impact of severity of illness in these children. So there's been about 130 cases of COVID throughout Australia and New Zealand as of 21st of March in children on active treatment for cancer, it affecting boys and girls equally. And the next slide, thanks. And if we look just at our WA data, we're about 10% of that data, although that 130 is probably much like probably more like 170, 200 now, and we're about 10% of the population. So we've had about 15 cases of children with COVID at the moment, of which only 6 have required to be admitted, and that's because of fever. Now, a child with cancer on anti-cancer treatment who has a fever has to call the unit and will be admitted. So they actually were not very unwell at all. In fact, they were pretty well, but they did have a fever. Remembering that children with cancer, we have to have a much lower threshold for bringing them into hospital if they've got a fever, because it could be that they have a much more severe underlying infection. So they generally come in and have antibiotics, and then we will observe them for at least 24 to 48 hours. And most of these children that came in with COVID, there's only 6 of them so far, have been very well. They've been obviously in a negative pressure room, isolated from the in another ward, completely separate to the cancer ward. And most of them have only been in for a couple of days. The remainder have been successfully managed on the SPARK program by Andrew and his team, as mentioned, and again have been very, very well. Next slide, please. some of the questions that came through were really around vaccination and who should be vaccinated. So that's why I refer you to the ANZCHU website. We basically are following and working closely with the ANZCHU guidelines, but essentially almost all children on anti-cancer treatment should be vaccinated. There are a few areas where we have to be cautious around certain of the treatments that the kids are receiving at the time. And for example, children that have had a bone marrow transplant, they have to wait a bit longer before being vaccinated because they just have no immune system to actually be able to uptake the vaccine. But the rule I would apply is essentially most kids the vast majority can be vaccinated. We have a slightly different schedule than in the non-cancer population, and we will speak to you about your individual child's needs as required. And in fact, because our borders actually were a bit delayed in opening, we have vaccinated the vast majority of our 16 and above because that vaccine's been available for longer for that age group. And then the 12 and above also. And then more recently in January, when the 5 to 12 vaccine came in, that delay in opening the borders actually gave us a bit of extra time to get a lot of those children vaccinated. So the vast majority of our children are vaccinated at least with one, most with two, and many with three now, with the booster where relevant. And so that has really been very successful with this wall of protection with the families being vastly vaccinated. There are some treatments that are emerging for the disease. That's another question that has occurred. So most of the treatment, so no child has needed specific treatment as such. They've just needed symptomatic support, as was discussed by both Andrew and Michael earlier, with regards to just observing. If they're coming with a fever in oncology, as I said, they will get antibiotics anyway because that's our standard. That's not necessarily because of COVID, but because if they have a fever, they could have another underlying more serious infection. There are some specific treatments. For example, steroids can be used to try and dampen the inflammatory response that COVID often has caused in the past in the other waves of the non-Omicron variant, where they've got severe respiratory distress. That's not something that we have witnessed all around the country. The experience has been the same as in Perth, is that it is a mild infection in the vast majority of children, and most are managed in the community, and some come in with a fever. But in the event that things do get more severe, and it's certainly possible, but we've not seen it yet, we can use these corticosteroids to dampen down the inflammatory response. And more recently, an antibody has been approved. It's got very specific indications, and they're all written there around the age, etc. And there's still not a huge amount of data because most of the data is in the adults, and even then, it's not in adults that have got receiving anti-cancer treatment. But it's an antibody that specifically targets the virus. It's given intravenously because it's an antibody treatment, but it is something that is available to us should it be required, and we would work very closely with our infectious disease colleagues to make sure that the children who might be eligible would receive it sooner rather than later. Next slide, please. So these slides really are around, again, the other measures that we have recommended, and these are the measures that are essentially recommended for everybody, but it's all sort of boils down to reducing the chance of being exposed and therefore infected by the virus. So again, this is something now when all this started, I'd never heard of physical distancing, but now it's like common language. Practice physical distancing and avoid busy areas. Wear your masks properly. Again, everybody wears masks now, socially acceptable. And hand washing. And there have been, actually, just as a side thing, there's been a lot of positives in terms of, I think, just general population improvement in hygiene and less transmission of other viruses as well as a result of COVID, because people are just much more mindful. And then other things like organized social gatherings outside, as Michael mentioned before, and both Andrew, A lot of it's to do with ventilation to try and minimize the virus sort of hanging around, so it's sort of airflow through buildings, and obviously gathering outside is much safer than gathering inside. Waiting for appointments outside or in the open, in well-ventilated areas, obviously avoiding public transport and ride shares. And if anyone in your household has or has contact with a person with COVID, developed symptoms, get tested and seek medical attention. So we would ask that if one of your children is under the care of our oncology unit, either because of cancer or because of blood disorders, if you please would contact us if they're test positive. Once we're aware, and if there's any changes in the condition, if the child does become a bit unwell, we're prepared, and that you would then come to the emergency department, as Michael discussed earlier. But also, it does impact on scheduling for appointments, chemotherapy, tests, etc. So the more information we have, the more we can then work around, because we'd like to try and keep the children's treatment on track as best as possible, and also make sure that we do the right monitoring for their individual cancers. Next, and I think this is the final slide. Maybe. These are just a few other tips. Again, they're common sense, and a lot of this really, it does boil down to just being sensible. But ask guests who are sick, have any COVID-19 or close contacts, ensure guests are fully vaccinated for COVID, including the booster shot. This is like that wall I was describing about protection. Ask guests to complete a rapid antigen test in the hours before the gathering. Again, that way those people that are meeting, you know, are negative. Encourage guests to use hand sanitizer when they enter, and keep some, again, this is something that you go to anybody's house or any shops, everything, there's hand sanitizers everywhere. I think this is only a good thing, and I think we should keep a lot of these actual measures in place. Ensure the number of guests allows enough space to physically distance. Try and gather outside. If you're indoors, open windows and doors to improve ventilation. Use the old elbow greeting or the namaste to say hello. Again, this has become now very socially acceptable. There's no big deal anymore. Obvious things, don't share cutlery, utensils, and avoid finger foods, especially younger kids. They don't really practice hand hygiene really very well. So I think that's it from the slides from me. I'm happy to take any questions with the rest of the panel. Thank you.
Great, thank you so much to all of you. I think you've given a really thorough overview of many of the aspects, and you've covered very well done many of the questions that people had. So again, I would just encourage people, if you did have, we've got just 10 minutes for a couple of extra questions, and so we've had some submitted in advance already, but if you do still have questions, please do pop them in the chat, and between Nadine, Tanya and I, we will get them asked. Now, we did have a question earlier about the prevalence of transmission in children and how it seems to be happening a lot more than perhaps we had expected earlier, perhaps in earlier phases a couple of years ago. And there was just a question in terms of, is it a point where we might be looking at more public health measures to reduce that transmission, or is it a constant balance between public health measures and the impact that those might have on things like people being more isolated versus the, you know, basically tolerating a certain level of transmission in the community? I don't know who might want to comment on that.
I'm happy to answer that one, Claire, if you like. The more modern variants are more transmissible than the previous variants. The original thinking that children were not a big player in the transmission of the earliest strains is true, but actually over time they have become more transmissible. The other important thing is many of those adults who were infected early are now fully vaccinated. So that's also pushing transmission into the paediatric sphere. And as that slide I showed, about 1 in 3 admissions are occurring in children or young people. It is a constant balance. I think we've all demonstrated to ourselves now that COVID's not going away. So we are going to have to tolerate a degree of transmission in the community. We need to balance that against what are we trying to do, which is really trying to protect people and try and avoid the severe outcomes with COVID. That is a constant balance. And a lot of the modelling and a lot of the public health actions are about trying to strike that balance between, one, protecting health systems, Also making sure that families are able to do what they need to do, go to school, interact in the community. It is a constant balance, and a balance that we're probably going to be struggling with for a number of months yet. And as we use those levers that we've got to basically increase or decrease, I think it's unlikely that we'll go right back to where we were as far as some of the strict lockdowns and things like that. I think the political appetite and also the public appetite for that is low, and it's probably not necessary at this stage. But on the flip side, I don't think we at this stage can go too far to the left-hand side. We still need to be very cautious.
Thank you, Chris. We've also had another question about, we've heard obviously a fair bit about long COVID. I'm coming with a very layperson's perspective, and what I feel like I'm not quite sure is do we know enough yet about long COVID and Omicron, or is that likely to still be emerging? But with regards to particularly the impact or the potential impact of long COVID in children and young people, what do we know, and what can we be doing, or what are we doing about that? And again, I'm not quite sure who might want to take that one.
I'll have first crack at it. It's a hard one. There's not a lot of data with Omicron, obviously, because Omicron's only been around for a few months. But what's really reassuring is again, very lucky that we've been able to learn from our colleagues in the eastern states that the vast majority, I'm talking 99.9% of children who have some symptoms following an acute COVID infection, their symptoms are fully resolved by 12 weeks of age. It's quite a different story what you hear about, certainly in in other countries around the world, in Europe and things, with that initial strains which came through. And but certainly it's we'll be monitoring and continuing to I guess we've also got services and models of care established, that there are children with persistent physical symptoms following any viral infection, whether that's glandular fever or COVID or anything else. There are some children who have those symptoms. We've got models of care and the ability to provide support and help to get them back to normal functioning. I think that might answer that.
Yeah, that's great, thank you. And again, I think a number of you have mentioned, and we've heard it from other conversations that we've had with some other teams too, about the reality, as you said, that we're going to be living with COVID for some time to come. And I have a couple of questions about that. One of them is, obviously, as we're going into winter, we've heard some media reports that might impact, there was obviously some reference to, I think, another expected wave perhaps in the budget papers. Is there anything that you can say, like what else can people be doing, or what else might we be wanting to think about in the community with regards to perhaps what's likely to happen over the West Australian winter with regards to COVID?
I'm happy to jump in there. Winter time is a time where it's more difficult to control respiratory viruses. That's a time when our peak activity normally occurs under normal situations. We spend more time inside, we spend more time with each other. So the same principles apply for all of those respiratory viruses as it does with COVID, and the same prevention actions are important. It is likely, as our international borders progressively open up, that we will get further infections such as flu from overseas. That is expected at this stage. So the winter time is an area of concern, particularly in Western Australia, given the fact that we will still have Omicron activity. We may have new viruses coming in. A couple of things. One, if you are eligible for your vaccine, to make sure that you're up to date and your family's up to date is the most important thing. And a bit of a plug, given the second booster recommendation, which started yesterday for those over the age of 65, those with severe immunocompromising conditions, and I can give more details offline to people and point them into directions of that. Make sure your COVID vaccine's up to date. One, make sure if you're eligible or recommended that you have an influenza vaccine this year. Although we haven't seen much flu in the last 2 years, we do expect it to see this year. And thirdly, stick to all those same principles, good hand hygiene, wearing your mask when you need to wear your mask, cough etiquette, all of those things are as relevant this winter as in any winter. And I'm hoping that we'll see a significant impact on our normal respiratory virus season again this year.
Thanks, Chris. Now we've probably got time just for one more question, and there still are a couple of others that are outstanding. I guess just signalling to Nadine and Tanya, I'm thinking that perhaps we might want to see whether or not there's interest in holding a forum for children or families and adults who might be medically vulnerable, and considering the question around the reality of living with COVID over the long term, and what are some of the ways that collectively as a community that people can respond to that. But we've had a couple of questions relating to COVID and pregnancy or newborns. So one was around, what do we know about the passing of antibodies from mother to fetus in utero, and can a newborn baby be born with immunity to COVID? And another question that we had was, what do we know about the incidence of COVID in newborns in WA, as they can't be vaccinated except indirectly through pregnancy and mum being vaccinated? So a general question there about newborns, babies in utero.
Jens, do you want me to take this one? So what we do know is that, one, antibodies do flow from mothers to babies. We do expect that offers some degree of protection, and importantly, we've seen very few very young babies admitted with COVID or presenting. That's not to say that young babies can't get COVID. Most of them are presenting with febrile illnesses like Michael described, but actually the very young, we have not seen large numbers, particularly in those first few months of life. So vaccinating mum protects baby. The other important thing is vaccinating mum protects the pregnant woman, because importantly, pregnant women are particularly susceptible to COVID, particularly the respiratory complications of COVID and to preterm birth. So importantly, something that we should continue to push forward, that all pregnant women are up to date with their COVID boosters, and we will continue to look to see whether young children are affected, but we're not seeing large numbers of that, particularly very young age group. It is important to highlight there are plenty of other children who are getting COVID, but most of them are doing very well.
That's great.
Can I just add something there? I guess there's a lot of sort of concern from mums when who may be testing positive, then with a newborn baby, what do I do? And certainly what we learnt in 2020 in other parts of the world, there was a practice where everyone was so scared of the babies getting COVID, the babies were taken away and put in isolation and separated from their mums, and that's had significant consequences. We know the importance of kangaroo care and breastfeeding on demand, and that's so really, even if a mum is positive to COVID, we're still encouraging them to care for their baby, breastfeed their baby. You can do simple things, wearing a mask, washing your hands and your breasts before you feed, having someone else to help look after the baby. But so there are things you can do to reduce the likelihood. But even if the baby does test positive to COVID, as Chris said, they would be eligible for the SPARK program, so we would monitor them. But again, it's something our colleagues in the eastern states. We've still got age of under 1 month as a risk factor in our SPARK. Actually, that's been taken out in New South Wales now. Actually, age does not seem to be, even that very youngest group, a risk factor for severe disease. But we've kept it there for now. But I think just, again, more sort of reassuring that actually manage things as you would do normally, breastfeed your baby, care for them as you would.
That's great, and thank you so much. And I'll echo a couple of the comments that are in the chat already. A huge thank you to our speakers today. I'm going to attempt to do a very brief recap. What we heard there, obviously, is that that wall of protection that you heard a couple of the speakers talk about is really important. So wherever possible, vaccination and vaccination. And as Chris highlighted, there has been some additional access to a second booster that started yesterday, and we'll include information in the email that we send out afterwards. The other comment that you heard there from Michael was to trust your gut feeling. And so you will know for yourself if something isn't quite right, how to reach out to and where to reach out to. And you heard about a couple of options there. There's obviously the GP, there are the respiratory clinics happening across Perth where you can be seen in person. And there's obviously, for people who might already have a specialist treating team, is to make contact with that team as soon as possible. And remember that for children who might have some risk factors, that there's a lower threshold for reaching out to the team. So to reach out as early as possible. we also heard, and this is something that, so Nadine has been running community conversations on this topic for a while. If you test positive, and when you get that message that says you've tested positive, you'll be asked to, there's 2 links in that test, contact them both. The first one will say, to help with contact tracing, please do this survey. It not only helps with contact tracing, it's the thing that will get you access to the COVID care at home, and in the case of children, to the SPARK programme that you heard about today. So please make sure that when you get that link to that survey, you fill it in, because that is your gateway to other care. You heard, like I said, about the SPARK programme, and again, we know there's a lot of community interest in this topic, and we will do what we can to see perhaps if we can chat to the PCH team and hold another session perhaps. We are a learning team at Health Consumers Council, and we have, Nadine has popped into the chat an evaluation form. We would really like to know how we can keep improving and what other questions you might have as you leave today. But for all that remains, we're cantering in just a couple of minutes over the hour-long session. Please join me in the traditional Zoom way of saying a huge thank you to Chris, Andrew, Michael and Nick. We know you're all very busy, and the comments in the chat again have been saying just how very positive and helpful it's been to hear from such an illustrious team of experts who've been able to really address many of the questions that people had. Thank you so much for your time. Like I say, we may run other sessions. You'll now be on our list. We'll make sure that we give you information. But yes, we have the normal Zoom way. You can or use the reactions field if you would prefer. But for now, all that remains is to say thank you very much. Take care and reach out for support when you need it. Thank you all.